So welcome to the first of our webinars on educational series around FeNO. First of all, I'd like to introduce Dr. Richard Russell. Welcome.
Hi, lovely to be here today.
Great. Would you like to introduce yourself?
Yeah,
First?
my name is Richard Russell. I'm a consultant chest physician at Southern Health Foundation Trust down in Hampshire. I'm the clinical director of respiratory medicine for the NHS South East of England, which keeps me busy. And I'm also a senior clinical researcher at the University of Oxford in the Nuffield Department of Medicine.
It's great. So thank you. I'm going to kickstart off with quite a general question, really. Why did you begin testing FeNO?
Well, my experience of FeNO goes right the way back. I was very lucky to be involved in the development of FeNO back in the late 90s in the Imperial College in London, the National Heart and Lung Institute. And so I was aware of FeNO, I was aware of potentially the use of FeNO and how we developed the technology. Of course, that was a laboratory-based thing, and now we've got this practical machine and also a practical tech tool which helps us directly in the management of asthma. So I'm now very involved not only in my practice in using FeNO to manage my airways patients better, but I also am investigating and researching how FeNO can be better used, particularly in primary care.
And that's great. And I think it's that use in primary care that we really want to start to understand and explore in the next few minutes. So following on from that question, can you expand a little bit on how it's utilized, how FeNO levels are actually tested in primary care?
Well, FeNO is an inherent part of the guidelines, both NICE guidelines and the BTS-SIG guidelines for asthma management and diagnosis. And there are several ways you can use FeNO. FeNO is the second test you should do after spirometry, interestingly, in both those guidelines. So we need to be doing it. Why? Because elevated levels of FeNO enhance your ability to diagnose asthma. Nothing is strictly diagnostic of asthma, but high levels of FeNO are very helpful with a diagnosis of asthma. And more importantly, high levels of FeNO are very predictive of response to inhaled corticosteroids. So if someone comes with symptoms, cough, wheeze, variable breathlessness, the classic symptoms of asthma, and they've got a high level of FeNO, you can have a high level of suspicion they really have got asthma, and also, and it's really important for the patients, a high level of confidence that they'll respond to treatment. So we use it in that way. And then the other thing, just to throw in, is we use it extensively in secondary care for adherence. People with asthma need to take their inhalers regularly, and we know that adherence is patchy at best. If someone's FeNO is high and you put them on inhaled corticosteroids, the FeNO comes down. They see that, and we'll talk maybe more about that. But also, if it goes up again, it either means two things. One is their disease has got worse and they're having a worsening attack, or it means they're not taking their treatment. And so you can then make an informed clinical judgment, putting it together with examination and other things to see what's really going on here. And patients really love it too.
That's great. What kind of feedback do you get? What do patients say to you? How do they express the importance of FeNO testing?
That's a great question. It's really interesting. Patients really want to know their number. If they've had, if you've got a patient, as I said, who comes in with symptoms, who's got maybe slightly poor lung function or a wheezy chest, and then they've got a high FeNO, all of those things are telling you the same thing. And they love that. They love the fact that things line up. And so they come in, a FeNO of 80 or 90, which is fairly typical of an early diagnosed asthma. And you then treat them and it comes right down. They get really excited about seeing that change because guess what? They're feeling better too. So again, the things line up, and that's really great for them. And when you follow them up and do it again, they're really excited about saying, well, what's my number today, doctor? And seeing where that is. So I think that's a really great engagement tool, as well as obviously a practical management tool that we can use in asthma and use the use of inhaled corticosteroids.
Yeah, and I think you touched on quite a few important facts, which we'll hopefully get a chance to explore in a little bit more detail. In terms of your practice, and in specifically referring to primary care, because I know you mentioned secondary care as well, how has FeNO testing changed your practice? How has it changed your patient pathway?
Well, FeNO is absolutely critical now in helping make a diagnosis of steroid responsive asthma. As a phenotype, as something which we need to do, it really is essential. You've got patients, as I said, with symptoms, spirometry, which may or may not be normal. That's asthma, that's why it goes up and down, but have got high levels of airway inflammation, and that's really important. Asthma is an inflammatory condition. FeNO, nitric oxide, is a production of the inflammatory pathways, IL-13, IL-5 pathways, which are driven by the inflammation. So why would we not use it to directly measure inflammation? Because it's not always true that inflammation and symptoms go together. Furthermore, we also know that high levels of FeNO in airway inflammation are predictive of future risk of attack.
Yes.
So if you're a patient and you're feeling okay, but your FeNO's 100, 150, there's inflammation there, there's a fire in your lungs. And so why wouldn't we treat it? Because we know at some stage that fire is going to get out of control, or there'll be an extra trigger, dog, cat, dust mite, all of those things that then tip you over to having a potentially fatal attack.
Yes, and I think that's the importance, is reducing that risk, reducing that element of risk in future exacerbations. So I think that's very, very, very important. Let's talk a little bit about the practicalities of FeNO testing, and I think it's important to start to understand what are some of the benefits of FeNO testing, but from a practical aspect.
Well, actually, it's really easy to do. I think that's really important. It's quick and really easy to do. I get frustrated, not the analysis, but when you put the machine on, it takes a little bit of while to get warmed up and get going. That's my biggest frustration. It doesn't come on immediately because I want it there and then and now. But actually, it's really straightforward and easy to do, and you get the results within less than a couple of minutes. So and it really helps you then, and it's real, it's live. So practically, it's of value then and in the moment. And obviously, when you've got, for example, practically when I've got a patient with me, I'll have the machine, I'll make sure it's going and ready. So I'll be taking the history of the patient, then we'll say, actually, hold on, let's do the test. And literally that takes, if they've done it before, it takes 20 seconds. If they've not done it before, it may take a minute or two to understand how to do it. But then we get the result, by which time we can be back into the taking the history, or even having a listen to their chest, or even doing spirometry. So the whole thing can be incorporated practically into the consultation as an integral part of the consultation.
Sure, and that's great. And do you would you test FeNO first and then follow through with spirometry? What is your order in terms
Usually,
of the testing process?
Yeah, that's a really good question. Usually I do. The reason for that is that we don't want them to think that they have to do a spirometry type breath, which is a very hard, long breath with a FeNO test, because it's completely different. So you mustn't do that. And then secondly, as I said, while the FeNO machine is calculating the result, I'm analysing it, I'm doing the spirometry afterwards. So usually I do FeNO, because also FeNO is a test. We've got a machine here, I could do this on you right now at this desk. Spirometry, I probably would need to take you to a slightly different clinical area, nose clips, mask, all the faff of paraphernalia goes with it, which we don't have with FeNO. So FeNO is very much a desktop test, whereas other things, listening to their chest and doing spirometry, would be in a slightly more clinical area.
That's great. Some really important practical considerations. So in terms of those practices in primary care that are currently not utilising FeNO as a test for diagnostic purposes or management of patients, what are some of your recommendations should they wish to implement that into their patient pathway?
It's a really good opportunity. It's a really great question again, because it's a great opportunity to think about how you manage asthma. And I do not see FeNO on its own. FeNO should be incorporated, as you've mentioned, into the whole management pathway, with the patient absolutely at the centre of that, and the patient journey at the centre of it. So it gives you an opportunity to rethink your pathways for a second. If you're not doing FeNO is part of effectively a structured review of asthma, which goes with symptom scores, which goes with spirometry, for example, or certainly peak flow testing, which may go with blood testing, and also with FeNO. So you've got to have a structured approach, and FeNO is part of the structured approach. We know that having a structured approach to asthma improves outcomes, so let's do it. And if FeNO is the thing that helps us structure that diagnostic pathway and management pathway particularly, then all the better. So I think it's really important to, in primary care particularly, think about your whole asthma pathway. Patient comes in with symptoms of asthma, or maybe having had an attack or something even worse. You've got to have a structured way of taking the history, looking at triggers, looking at impact, looking at potentially then compliance or with the treatments, etc., and previous history. You want to have a structured approach to then the diagnostic testing, which will be spirometry and FeNO, potentially blood eosinophils, markers of allergy, etc., that comes out of the history, and then a structured approach to management with a clear way of starting treatment, perhaps driven by FeNO, but certainly saying, you know what, you've got inflammation, you need to be on an inhaled corticosteroid, let's get you on it, and then let's review. So structure review to close the loop is also really important.
I think that's great. Do your patients at every consultation have a FeNO test?
Yes, actually they do, and I do it myself. I have a team potentially who help with other things, with education, with my inhaler sometimes, and with spirometry, but not always. And actually, I tend to do the FeNO myself because I absolutely incorporate it into my consultation. It's like just like us sitting talking now. We would just have it switched on, and we would just do it literally because it's so quick, it's so easy, and also it enables me to instantly get the biologic feedback, which I'm also hearing from the story. So if you're telling me, well, I've not been so well in the last week, and I'm waking up at night, I'm coughing a bit more, and I'm wheezing a little bit, and yet the FeNO comes back at 70 or 80 or more, whatever, a higher number, then I'm saying, you know what, I agree, you're absolutely spot on. These two things, your story and the machine, add up, and so I need to increase your treatment, and that's immediate, and they really love that and they get it. Similarly, or on the opposite side, if you're telling me you're not very well but the FeNO is really low, we need to think about other things. What else? So it drives the consultation. Do you see what I mean?
Absolutely.
So I don't like to use it necessarily as just a test on its own, because I like to use it in a practical way right there and then, because if your FeNO is low, well, is it that you've got something else going on? Have you got some sinusitis coming on? Have you got some reflux disease coming on? Do you need more bronchodilator rather than inhaled steroid? And that's what may well be suggested by the FeNO test. So it's a great way of triggering a structured approach to the discussion.
And I think that's you've touched on quite a few different concepts there in that last question that I asked. Some of the patients that you mentioned different types of patients, but can you give us a bit of a summary of the most appropriate types of patients that you can really target and you think, well, these are the most appropriate patients where a FeNO test is going to be of value?
Well, I think FeNO is really of value initially at making the diagnosis of asthma. It's clearly a value because a high level of FeNO, as I mentioned, is predictive of asthma. Nothing is unfortunately absolutely diagnostic of asthma, but it helps you with that early diagnosis. I think also, as I've mentioned, it helps you very much then solidify the role of inflammation in people's minds and the need therefore for treatment. And then in the follow-up, it's extremely useful for adherence checking, in that, as I mentioned, if FeNO is high and the patient tells you they're taking their treatment, either there's inflammation residual, they need more treatment, or they're not taking it, and that's worth then delving into and investigating. Or they're not taking it right. It may not be their fault, and let's not do that. We'll just do it in a very non-judgmental manner. And then FeNO. So therefore, FeNO is valuable in each of those things. And then the other thing, which I'm going to touch on, and it's very useful in clinical practice to us respiratory physicians, and it should be in primary care, is the use of FeNO in cough.
Okay.
So some really nice studies have shown, and this is one of the great things about FeNO. FeNO is practical. The results from studies can be implemented in practice So there's some really nice studies which show if someone comes with a relatively vague respiratory symptom, cough, it's a nasty symptom. Let's not, cough can be very debilitating. But there are lots of causes of cough. We've ruled out the nasty stuff. We haven't got cancer. We've not got pneumonia. But someone's had a cough for 3 or 4 months. FeNO really helps you predict response again to inhaled corticosteroids. So if the FeNO is above 40, for example, you are likely to respond to steroids. If the level is below that, I wouldn't bother with that treatment. So it helps me in that moment, again, direct treatment for a non-specific symptom, which otherwise is really hard to chase down as a symptom, yeah?
Yes.
So it can be very useful in that way, and there's several studies now that show that, and I implement that in my practice because cough, although it's perhaps never going to kill someone, is a significant morbidity and also user of healthcare resource, both in primary and secondary care.
Very interesting. So coming back again to practical aspects of your consultation, when you're particularly with those patients who may not have had a FeNO test before, how do you educate them on the importance of FeNO? And even discussion, we talked a little bit about non-adherence to ICS treatments. How do you educate your patients around those behavioral risk factors?
That's a really good question. Let me maybe break that down a little bit. First of all, do I have any problem with patients doing the test? Very rarely, because they see the device and they love a gadget and they think they love that. And they also, as I mentioned before, love the personalization. This is their number.
Yes.
It's not my number, it's their number, and it's not a random number, it's the level of inflammation in their lungs, and they get that. And I think that's a wonderful thing to be able to, because communication, what inflammation is hard, but to show them the results of inflammation, and then as I mentioned, then treating someone and it comes down, they go, wow. And I think that really opens the door to a whole different, you see the light bulb come on, so a different approach to their asthma. And then your second point, could we do that second bit again?
So how do you educate them in terms of the compliance elements, so the non-adherence, those patients who are not adhering to their ICS treatments?
So I think it's, so the use of FeNO in asthma, I think you use it or you don't, meaning you've got to be consistent with it. And so the education begins at the beginning, as I've mentioned, and explaining inflammation and what that means. And then at follow-up, doing it for the same reasons, to reinforce the messages, reinforce the huge message, which is if you've got asthma with airway inflammation, you need to have inhaled corticosteroids to be taken regularly. So that's really a clear message at the very beginning. And FeNO reinforces that. And clearly, when you're doing follow-up visits, use of FeNO can help you advise and demonstrate in a visual way what's going on then. So, as I've mentioned, someone swears they're taking their treatment and they tell you they're well. I do 2 things. First of all, you've got a FeNO test, and the FeNO will tell you whether their inflammation is under control. Under control, happy. If it's high, you can then say, well, actually, when you started your treatment, before you started treatment, your FeNO level was 90. It came down to 30 with treatment, and now it's back at 90 again. Why could that be? And then secondly, it really is important to delve into the symptoms, because if someone tells you they're well, if you ask someone with asthma, how are you feeling? They'll say, I'm fine. You can stop there. No, you must not stop there. That's absolutely wrong, because you've got to delve into the individual. Are you coughing? Are you sleeping? Are you using rescue therapy? All those other things. Are you more breathless? All those other things that could be going on. So you'd use the FeNO to then drive a discussion about what could be going on. So, okay, are you really well? Well, yeah. Really? How are you sleeping? Well, I cough. You coughing at night? Yeah, I wake up twice a night. That's so common.
Yes.
And then you go, well, hold on, that's exactly what the FeNO is telling me. And there's reasons for that. So yeah, they said, oh, I feel well, so I've stopped my treatment. Well, maybe that's why you're coughing again and why the FeNO is high. So you can see how that then turns into a discussion, which is positive. And then, and this is the other important thing, we then need to have techniques and ways of treating patients which work with the patient. What I mean by that is, it's no good me just telling you, you've got to take your inhaler. They know that, kind of. We hope they know that, but they're not maybe doing it. So we've got to find a way of using the inhalers that work for them, getting them to use them. Do you see what I mean?
Yes.
So maybe in a slightly more flexible way, rather than you must take this twice a day, otherwise you're going to die. Because that's not going to work for people, is it? Or not many anyway. But actually saying to people, well, it's interesting, isn't it? Your level of inflammation's high. Maybe you're not taking your inhaler quite as often as you should be. Tell me, how are you using it? And they'll say, well, I just use it once a day and I sometimes forget. Well, that's okay. But how often are you using your rescue therapy? Well, I'm using that 4 times a day. Okay. How about we then try and combine that approach and say, well, maybe you should be using your preventer therapy much more often, much more regularly, or we also have, you should be aware that we have drug combinations which enable us to take that kind of flexible approach. And FeNO can be a great way into that as well. So really improving adherence.
I think that's a great summary in terms of some of the educational elements and how you interact with patients. So we're coming pretty much to the end of our discussion, but I think what I would like to ask you is if there were 1 or 2 patients that you could think about where you feel that FeNO has been absolutely instrumental in improving their airway inflammation and improving their life and standard of care. Those 1 or 2 patients, could you give us a little bit of insight into some of their background and how FeNO testing has really elevated the standard of care and improved their lives?
Yeah, that would be a pleasure. I mean, you can think of so many moments, and I mentioned the light bulb moment. I really want to push that because FeNO is a great diagnostic tool, and people don't like to be labelled sometimes, and maybe don't like to be labelled as having asthma and being asthmatic. Yeah, and so they often ignore and neglect symptoms for years sometimes, and then eventually something will happen, and they'll be sent to see us and have some tests done. And the history is everything, taking the detailed history about what's going on, and at the same time I then do the FeNO test, and they're saying, well, I'm all right, I can get by, and it's all good. Yes. But the FeNO comes back at 90, 100, high levels of airway inflammation, and you say, well, it's interesting that there's a fire going on in your lungs. There's this test, which is a direct measure of inflammation, is telling me you've got a fire going on, and we need to treat it. And you can see in their mind a little bit of churn. Maybe I shouldn't put up with the symptoms I've got. Maybe I shouldn't put up with the breathlessness. This is telling me I've got a problem. The doctor's agreeing. Maybe I should take this seriously. And you see that light bulb, and then ka-ching. And then to finish with that kind of patient, to reinforce it, they come back to you having taken the treatment for a few weeks even, and you do the test and it's down at 20, and they feel better, and they go, wow. And literally they'll say, you've changed my life. Well, it's not me, it's the medication, but it's also been assisted by FeNO reinforce that message. If I was just without the FeNO, I could perhaps do it, but it wouldn't be quite the same light bulb moment. So that's one really important type of person that kind of I worry about, because they've got airway inflammation and they're ignoring a lot of their symptoms. More often men than women, and more often a little bit older than younger. And then I think the other one, which is really challenging, slightly more challenging, we've mentioned adherence. And the use of FeNO into having a structured discussion about adherence, about what it is, what it means, is really valuable. There's great evidence that people who are less adherent to treatment end up in hospital more, have more morbidity, have more death. And we could understand that by talking to them, or by checking things out. It's actually really difficult to check adherence. When we're doing severe asthma stuff, we spy on them with digital little devices in their inhalers and things, but that's part of the test for a different reason. But FeNO really helps us with that in the moment. It's not all of it, but if you're in primary care, and as I mentioned, you're doing one of the primary care respiratory nurses or GP is doing an asthma review, having FeNO as an integral part of your review and structure will give you a window. And I think that's quite a good way of looking at a window into the patient's adherence, because again, there may be a disagreement, between what the test is telling you, what you're feeling as well as a doctor or a nurse. You think, really? And then what the patient's telling you. And I'm not saying we'd put it all right. It's not just a solution, but it gives you a window into their world, and then you can then say, well, as I mentioned, doesn't seem to be quite right. Let's talk about what you're actually doing, and then we've got solutions. So it's I've had lots of people like that. They're work in progress.
Sure.
And I think that's very important. And you don't use it like I'm checking up on them. It's not like that. It's like well, actually, this machine seems to be telling me there is inflammation there. So let's have a look at that and see just how you're doing. Because you may find that they've got a problem with the inhaler, or there's side effects with it, or the technique's wrong, or something really simple to fix. And so that could be the issue. They're not deliberately non-adherent. It's just that they are not getting it right. So that's a great opportunity, and that can trigger that discussion.
Well, it's been a pleasure talking to you this morning, Dr. Russell. Thank you very much for joining us and sharing your insights with us.
Thank you very much. It's been a really valuable use of time, and I hope and I expect this will change and improve asthma management in this country.